My name is Jesse McIntyre, and for my applied research project, I looked into administering patient-reported outcome measures to the patients that I was treating at my institution. Patient-centered care means taking the patient's values, preferences, and concerns into account when determining the care that will be delivered. The patient should have an active voice in the clinical decisions that are made. Patient-centered care is considered a core health competency, so it is expected of all healthcare professionals, including athletic trainers. Patient-reported outcome measures are instruments used to understand the patient's perception of the health condition and that condition's impact on the patient's quality of life. Patient-reported outcome measures are essential to delivering patient-centered care. Benefits of patient-reported outcome measures for athletic trainers include enhanced communication between the clinicians and the patients as well as other clinicians. Includes more information to direct the plan of care, as well as more efficient examinations, and patient-centered interventions that improve the patient's perception of the thoroughness of care that's being delivered. Barriers to the use of patient-reported outcome measures in athletic training include the additional time needed for the patient to complete the instrument and the clinician to grade it. The instruments can confuse the patient and be difficult to complete, and the instruments can provide information that is not necessarily useful to the clinician. The athletic trainer must understand these barriers beforehand and develop strategies to overcome them when administering patient-reported outcome measures. These measures can either be region-specific, assessing function of an individual body region like the near shoulder, or generic, which assesses global function and health-related quality of life. Generic instruments also address psychological effects of injury. The athletic trainer must determine what instruments are most appropriate for the setting and the population being treated. Athletic trainers should utilize patient-reported outcome measures and should teach the use of these when acting as preceptors. Still, only 26% of athletic trainers use patient-reported outcome measures and only 30% of athletic training preceptors. Unfortunately, this prevents athletic training students from learning how to utilize these patient-reported outcome measures and prevents them from using them as entry-level athletic trainers. The project was conducted at a Division II sports medicine clinic, which treats roughly 400 student athletes across 17 sports. There are 8 certified athletic trainers responsible for the care of these athletes. Documentation is done in 2 forms, on paper and electronically. The EMR that is used at this institution is complicated when trying to obtain notes from individual treatment sessions, making it difficult for athletic trainers to look back quickly at previous visits. By using a paper format as well, these notes are much more accessible. Still, the only patient-reported outcome being assessed was a numeric pain scale taken at each visit. This diagram describes the methods, facilities, and people available and the current information being taken. These lead to a lack of health-related quality of life information. This causes a gap in care at this institution. Due to the lack of health-related quality of life information, patient-centered care could not be performed. The introduction of PROMs into the care of these patients could close the gap by providing information on the effects of the condition on the patient, as well as quantifying results which would lead to more informed care decisions and improved outcomes. The goal of this project was to select a patient-reported outcome measure to use with this population and then administer it to patients in at least 85% of eligible patient encounters. Initially, the focus of this project was the care delivered to men's basketball players at this institution. There were 15 student athletes included, and there could be anywhere from 2 to 8 patient encounters per day, involving both upper and lower body injuries. Last year, knee and thigh injuries were most common, followed by ankle and foot, and finally shoulder and arm. For each new injury, a full evaluation is performed, including history, observation, palpation, range of motion, strength testing, special tests, and neurovascular screening. On follow-up visits, a short progress note was taken at each visit reporting on what the patient stated regarding the condition improving or worsening. Patient encounter procedures are detailed here on the flowchart. As noted, there are no patient-reported outcome measures being used in the care of these patients. The project would be evaluated based on the number of patient-reported outcome measures administered compared to the number of visits that it should have been administered. The aim was to administer the patient-reported outcome measure at initial eval, then once weekly until discharge. For those patients already being seen at the beginning of the project period, the measure would be assessed on the next visit and then once weekly until discharge. For this project, I utilized 3 plan, do, study, act cycles over the course of 6 weeks to implement a series of changes into the process of care and implement patient-reported outcome measures into this process. For the first cycle, the gap in care was identified and a literature review was conducted to determine the benefits, barriers, and best practices for implementing patient-reported outcome measures in athletic training. It was determined that the disablement in the physically active scale, or DPA, would be best for this setting and population. Before administering this instrument, I became proficient in administration and scoring, then printed out hard copy DPAs and placed them near the paper copies of the patient's injury files. The DPA is a generic patient-reported outcome instrument. It utilized 16 items scored from 0 to 4, and these scores are added up and measured against a 64-point max, with higher scores indicating greater disability. The DPA has been shown to be both valid and reliable for college athletes and was therefore the most appropriate instrument for this project. Here's an example of what was given to the patients. It is a hard copy of this disablement in the physically active scale. You can see here they measure anywhere from 0 to 4, and then the final score is taken out of 64. On each patient's next visit, the DPA was administered. DPA was added into each initial injury evaluation as well. Each patient continued to complete the DPA once weekly until discharge or lost to follow-up. I scored the DPAs and recorded the scores both in the paper injury file and the electronic record. The first cycle lasted 2 weeks. To study results of the first cycle, the number of completed instruments was compared to the number of eligible visits. As shown in this table, 100% of patients seen completed the DPA each week. After discussions with patients and the professional athletic training student assisting in the administration, it was determined that the document storage was not convenient. Storing the completed DPAs with each patient's paper file was creating clutter and confusion. Also, some patients scored higher than others on the mental component of the DPA, and there was no plan in place on how to address this. To address these challenges, completed DPAs would need to be moved and stored in a more convenient central location while still maintaining patient privacy. For ease of access, it was determined that the blank instrument should also be stored with the completed instruments. It was also determined that to address high scores on the mental component of the DPA, another patient-reported outcome measure would need to be added to assess the need for immediate action and track the effects of injury on anxiety and depression symptoms. For the second PDSA cycle, completed and blank instruments were moved to a binder that was kept in a locked office in the athletic training clinic. This maintained privacy standards while making the instruments easier to access. Also, student counseling services were consulted on PROM usage, and they reported that they used the Patient Health Questionnaire 9, or PHQ-9, to assess and track depression symptoms. To maintain continuity of care between the two departments, I decided to use this form as well when assessing patients. The PHQ-9 is an instrument developed for and encouraged in primary care practices. It is meant to be given at the initial suspicion or diagnosis of the condition. It's a 9-item scale that measures depression symptoms, which are associated with a DSM-4 on a scale of 0 to 3. These scores are added up and the severity of depression is determined by a scale included with the instrument. Here's an example of the Patient Health Questionnaire 9, which was completed by patients in the athletic training clinic. It was decided that a mental score of 3 or more on the DPA out of 16 would trigger administration of the PHQ-9, and scores indicating major depressive disorder or an affirmative response to the question regarding thoughts of self-harm on the PHQ-9 would trigger a referral to student medical services. Administration of the DPA continued as normal, with each patient seen completing the instrument once per week. The PHQ-9 was administered as needed. The second PDSA cycle lasted 2 weeks. As seen here, the rate of administration stayed consistent. During week 3, one patient completed the DPA but then did not stay for treatment, resulting in one more completed instrument than recorded eligible visits. Also, the PHQ-9 was administered to all patients that met the criteria during the second PDSA cycle. The next step in the process was to formulate and implement a spread plan. It was determined that the most appropriate person to start with would be the intern athletic trainer working with women's basketball that I was responsible for supervising in his clinical responsibilities. An issue with this, though, was that the intern kept all records electronically. He did not keep up with paper records to go along with it, making it difficult to compare PROM administration to eligible patient visits. It was determined that a paper treatment log would be needed to record who was seen, when they were seen, and if the PRMs were administered. To begin the third PDSA cycle, the intern athletic trainer was trained on how to administer, score, and evaluate the DPA and PHQ-9. A sign-in sheet was created to keep track of who he was seeing, when he was seeing them, and if he administered the patient-reported outcome measures at that visit. This had two effects. First, it served as a reminder to administer the DPA and the PHQ-9 when necessary, and made it easier for me as the supervisor and the project leader to review and evaluate. The administration continued as before, with the addition of the sign-in sheet for the intern athletic trainer. All records were still kept electronically as well. Eligible patient encounters and PROM administrations were compared as before, with the addition of the sign-in sheet. Barriers were discussed with the intern athletic trainer. As shown here, the 100% rate of administration was maintained for both the DPA and PHQ-9 for both men's and women's basketball student athletes. No barriers to the administration were experienced, so administration continued throughout the semester. The intern athletic trainer was evaluated weekly to assess compliance and address any other concerns. The biggest limitation to this project was the number of patients seen. There were not enough patient encounters to show all of the potential barriers to PROM administration in this setting. This makes the results less relevant to a bigger setting. If the same project were conducted by the athletic trainer working with football, for instance, the barriers might be more prominent and have to be addressed differently. Another limitation was patient compliance. This did not necessarily affect the project goals, but it did affect the usefulness of the project. If patients came in every day for a week and symptoms improved, they might not come in again until the symptoms return. That might be a few weeks down the road, or it could be the next week. Unfortunately, this would prevent tracking results because only one DPA would be completed. There would be no previous score to reliably compare it to, and no later scores to determine effectiveness of the treatment that was delivered. A lesson learned was the need for a strategy to monitor and address mental health. Before this project, the only procedure relating to mental health was the Mental Health Crisis EAP, which would be activated when a student athlete threatened harm to him or herself. By addressing mental health earlier, using patient-reported outcome measures to determine the need, hopefully the crisis can be avoided altogether. In addition, the addition of the PHQ-9 also gave me an opportunity to improve communication between student counseling services and sports medicine. This improved communication enhanced interprofessional care and maintained continuity of care by cooperating on the PROMs being used. In conclusion, the addition of patient-reported outcome measures into routine care increased the amount of health-related quality of life information available and enhanced patient care. Through this project, the information was available for 100% of patients that I saw, plus the patients seen by the intern athletic trainer from the start of the third PDSA cycle to the end of the semester. This project showed that with proper planning, the use of patient-reported outcome measures could be added into routine patient care and even lead to more open communications on topics such as mental health. I would say that the most important outcome of this project was the handful of patients that I was able to refer to counseling so that they could get the help they needed but didn't really know how to ask for. Future projects should aim to expand the use of patient-reported outcome measures so that all patients seen in this clinic can receive care based on their health-related quality of life. Thank you for watching my presentation, and thank you to Dr. Anderson and all the people I've gotten to interact with over the last 3 years that helped me complete this project and hopefully make my DAT a reality.